So today, dear all, I welcome you in our e-Gurukul Pathshala PG Clinic platform. And today we have the case discussion on neurology. And for this, we have presenter Dr. Anuj Modi with his mentor, Dr. Bhumika Patel. Dr. Bhumika Patel is an assistant professor, and today we have the presentation is from MK Shah Medical College and SMS Hospital, Ahmedabad, Gujarat. For today's case, we have Dr. Ritesh Shah as an expert. Dr. Ritesh sir has done his MBBS from BJMC and MD from VS Hospital, Ahmedabad. He has done his fellowship in pediatric neuro from Hinduja Hospital, Mumbai, and clinical neurophysiology fellowship from Cleveland, USA. He is practicing since more than 12 years at Surat as a pediatric neurophysician and published many papers and written chapters in books on the various topics. I welcome you with Ritesh sir.
Thank you.
We have our Guru, Dr. Baldev Prajapati sir, here to take us through the journey of learning, and we all learn a lot from you, sir. So platform is all yours.
Good evening, friends. Welcome to this our Saturday PG clinic. I welcome Dr. Ritesh also and Dr. Bhumika. Anuj, I request that you may convey our other colleagues to join.
Yes, sir.
So that probably we can have the good interactions and even we can make it more interesting.
Yes, sir.
I'm sure that your friends, colleagues must be there.
Yes, sir. Yes.
Maybe on the attending link, request them to come on this panelist link.
Yes.
Anuj, you know that our main purpose of discussion is not the diagnosis.
Yes, sir.
We want to learn that how best we can analyze whatever the problems, complaints, and what will be our thought process so that gradually we can have some ideas that what is the likely problem.
Yes.
I think with that idea, we will start the history part. You can share your PPT and start the history.
Okay. Good evening, sir. I am presenting the case of 12-year-old female child residing at Chandkeda, born out of non-consanguineous marriage, Hindu by religion, belonging to lower socioeconomic class, informant being mother, who seems to be reliable, presenting with the chief complaint of weakness of right side of the body with deviation of the mouth to the left side since 1 day and inability to speak since 1 day. On origin, duration, and progression, child apparently well before the 1 day. At the 10 a.m. morning, she was sitting comfortably and she tried to stand up and she fell on the ground and she could not move the right leg and hand and she made to sit with some support. In an hour or two, mother noticed that she is unable to hold uh, unable to hold the thing in the right hand and she could not raise the right arm above the shoulder. While lying in the bed, she could not move her right leg and was unable to lift her leg above the bed or move her right feet on the command. So within a few hours, child was bedridden. Her movement on left side of the body was normal. She could turn on the bed from left to right, but not a vice versa. She could lift her head of the above bed, and according to mother, the weakness appeared equal in both upper limb and lower limb. Weakness has maximum at the onset, The next day, there was some improvement in weakness. At the time of admission, on day 2 of illness, there was a flickering moment in upper limb and lower limb, and by the end of day, she could lift the right upper and lower limb minimally. Along with the weakness, parent noticed the deviation of the mouth toward the left side, and there was no drooling of saliva. Child was keeping the eyes shut during the sleep, and there was no improvement in deviation of mouth with the complaint persisting on admission. With the starting of complaint of weakness within an hour, the child was not able to speak anything, though she understood and obeyed the instruction by the non-verbal gesture, like nodding her head or indicating using her left hand. Mother noticed that child has able to speak the few words like yes, no, ma, papa since the early morning of the day of admission. And there is no history of loss of vision, double vision, deviation of the eyeball, drooping of eyelids, numbness of face, difficulty in chewing, impair the hearing, nasal regurgitation, neck flop and choking, or gagging and deviation of tongue. There is no history of loss of consciousness, seizure, abnormal movement, vomiting, headache, stiffness of neck, irregular or fast respiration. The child has been recognized a family member throughout the illness. There is a no history of loss of perception of touch, hot or cold or painful stimulation on the right of the body. There is a no history of bladder bowel involvement or urinary fecal incontinence or retention. No history of trauma to head or neck, or no history of suggests the intraocular trauma. No history of filled skin lesion over the body in the recent past, and there is no history of preceding fever, vaccination, or respiratory distress, ear discharge, vomiting, loose motion, burning micturition, rashes, or chronic discharging sinus. There is a no history of perception of the heartbeat, breath sound, bluish discoloration of tongue, lip, mouth, nail, or on crying, and increased sweating or easy fatiguability. There is no history of pain in abdomen, pallor, jaundice, pain in feet or hand, rashes, bone pain, swelling in the body, or blood transfusion. No history of suggestion of photosensitivity, joint pain, abnormality of gait episode, and vomiting and confusion. No history of abnormal urinary or body odor, vitis opacity in the eye, yellow black deposition in eye or elbow, and hyperpigmented erythematous lesion and spiny deformity increase in the mobility of joint.
Okay, I think, can you stop sharing, Dr. Anuj?
Yes, sir. Yes, sir.
I think you provided the extensive information. I'm sure that most of the students should be able to think. Are there other students with you? I think Dr. Harsh Kalaria is from your institution, because I would like to identify them. Dr. Anuj,
Yes, sir.
are there other your friends on the screen?
Yes, sir.
Dr. Harsh from,
No.
I will say, is a student. Dr. Harsh, can you make it your video?
Yes, sir. Yes, sir. Yes, sir. Sir, KM Hospital, Pune.
Oh, I think why there is this echo? Whether are you using the two modes?
Sir, no echo now. You can go ahead.
Okay. But let us start from you then. I'm sure that you must have thought of, because already you know the details of the illness of the patient.
Yes.
Always in the discussion, try to understand in a CNS case, as a whole in any system, but more so in the CNS case particularly, that where is the anatomy?
Yes.
Which part is affected? Try to identify number one. Second, try to find out the answer to the question, what type of the insult it is, what type of pathology is likely. And third, is there any possibility of some etiology which you can mention? And fourth, usually, what is the present status of the function of that organ involved? I'm sure if you answer these 4 questions, almost probably you have reached to the possibility. Having this, let us start the anatomy.
Yes.
What is your idea? I think already you described the 12 years old female.
Yes, sir.
She was not having any complaint before
One
this
day.
particular episode. And that started very, I will say, very nicely described that she was sitting and how she noticed the weakness on the right side. Later on, this particular deviation of mouth and even the speech involvement. I think mainly these 3 components you have described.
Yes.
Having this, what will be your idea that where is the site of lesion? Which part of the nervous system is affected? Can you think over it?
Yes, sir. First is a central nervous system affected, and it is a cortex part affected because of the speech involvement.
Okay.
I mean, right-sided weakness with the speech difficulty, right, and deviation of the mouth toward the left side. So it is mostly due to the upper motor neuron lesion. Due to pyramidal tech effect affected, mostly cerebral cortex is affected.
Okay, so motor deficit, the right side motor deficit or the weakness,
Yes.
you consider that it is likely due to the cortex pathology, right?
Yes.
I think you must be knowing in the cortex representation of the parts of the body. Suppose the right side of the body is affected, problem should be in the left hemisphere.
Yes.
Am I right?
Yes, sir.
And in the left hemisphere, you know that there is a wide representation. That means extensive involvement of the left hemisphere should be there.
Yes.
If is it so, then what will be the usually situation of the patient? Is it so that otherwise, okay, weakness is there, speech and even the deviation of mouth problem, but otherwise she's not bad.
Yes, sir. It is higher mental function is normal. It is
So do you expect in the cortical involvement like that? And as I said, the very first point which we should think that when half of the body is affected, the opposite whole hemisphere is to be involved. Then and then this type of weakness. And that too may not be uniformly the same involvement of the upper limb, lower limb. Because there can be some difference in the power or something. So how will you explain this part?
Because of the hemisphere is supplied by the only not a single artery. It is supplied by the more than one artery. So not all part of the celeb smear affected at the time.
If it is not so, then the motor deficit should not be in this way. Suppose what you are making the argument or explanation that cortex is getting the supply from multiple places.
Yes.
That means perfusion is maintained, maybe compromised, but maintained.
Yes.
If perfusion is maintained, why so much extensive motor deficit of the half of the body? It should not occur. Am I right?
Yes, sir.
Okay, keep it like that. Up to that point, you can keep. Second point, suppose cortex is involved, what other higher functions will be commonly involved or presentation? Symptoms complex.
If cortex involved with seizure disorder.
Yeah, seizure is common. What are other things?
Then cortical sensory loss, there is cortical sensation.
I will say rather than the complex, keep it simple. What happens to consciousness? With the cortical involvement, the person will be totally intact, I will say alert, oriented. The way in which you are describing this girl is orientation point of view not bad.
Yes, sir.
No seizures.
No seizures.
So all these points, whether they are favoring you to localize the problem at the cortex, or it should be somewhere else. Anyway, let us see the others. Somehow others have not located their name. I think Dr. Maulik. Maulik, can you make your video on? Anyway, suppose another thing, you know that when this is a compact problem,
Yes, sir.
and that means suppose pyramidal fibers are affected, where the likely pathology, where the dense hemiparesis or hemiplegia can develop. Is there any other place?
I, internal capsule is affected because leading to the both of face, upper limb, and right limb equally affected. So
Yeah.
that time is a hemiplegia.
And you know, if the internal capsule, you know, the very compact fibers are there.
Yes,
Pyramidal tract fibers are at the dense. And suppose if it is affected due to any pathology, opposite side is going to be reflected in the body motor deficit.
okay.
Suppose if you consider internal capsule for a moment, how will you explain this deviation of or asymmetricity of phase? I hope that what is your interpretation for that asymmetricity of phase?
Because of upper motor neuron involvement.
Where is the but which part is affected?
Uh,
Which I will say nervous system component is affected?
means
You know, with the manifestation, clinical manifestation, you always try to locate that which part of the CNS is affected. Suppose here asymmetricity of phase. Then where is it only the internal capsule or some other component is also likely involved?
Sir, Dr. Harsh has replied for internal capsule.
Yeah.
So, all the students, a sincere request, please participate in the discussion by putting your mic on. It's not necessary to every time write in the chat. You can put the mic on and you can reply.
Rather than I will say putting on the paper, you will have to answer. And in the exam also you have to answer. The examiner is not going to provide you the paper to write down the answer. And he has to answer on face. Right. Asymmetricity, Anuj, which cranial nerve is likely involved?
seventh cranial now.
So why it requires so much time to think? Right. It indicates that likely the seventh nerve is involved.
Seventh cranial.
Can you make it that what type of the lesion, upper motor or lower motor? Because you have described to some extent, still probably your examination may be clear.
It is a upper motor neuron because of the opposite side of the deviation to the mouth.
Okay. And how will you explain the speech involvement?
Uh, because of the speech more, it is a most likely the motor aphasia. Due to the motor aphasia, Broca's area is situated in the frontal leading.
Okay. So probably now with this discussion, what you will consider your anatomy?
Yes.
What will be your final answer for the anatomy?
Yeah, it is cortex, cerebral cortex involvement.
Okay. Is there anybody who is supporting or different? I think Dr. Lata. Sorry, I do not know exactly that. Is there anybody, faculty, or I think faculty can also give the opinion that I don't agree with this discussion. That becomes a good discussion. Or even if we can put our own interpretation. Dr. Maulik? You know that unless participation is there will not be the discussion, just it will be monologue or some only just like the information providing. Anyway, Anuj, what we can consider the pathology, that whenever these type of this motor deficit, half of the body, that indicate that these compact pyramidal tract fibers are affected
Yes.
rather than the scattered fibers. In the cortex or corona radiata, the fibers are scattered. And to involve these fibers at a time, there should be the extensive lesion. That will be the different type of presentation. So I think here likely the internal capsule. We can explain that, yes, seventh now, if you remember the anterior horn, genu and posterior horn of the capsule. And I think nearby genu, even the facial nerve nucleus is also located. So likely the involvement of it. Speech we can explain whether it is really due to the motor part or even the way which you are describing, that even these, speech has two components, motor and the sensory. I think here the person is not able to speak, otherwise able to understand everything. We consider this motor part, and that you can put even in the cortex, the Broca's area, which is located in the parietal lobe also. Okay, I think this much we can consider the anatomy. Let us see the detail, but before that, one more point. What type of pathology is likely? Is it due to some, let me give you the idea, is it due to some trauma? Is it due to some infection or inflammation? Or is it due to some vascular? Vascular also you can think, is it due to some embolism, thrombosis or hemorrhage? Or really some neoplastic, some autoimmune disorder, neurometabolic, degenerative. So many headings are there and every category is having the characteristics. So having this idea, just I want to give some, I would say, points to think. What will be your thought process? That what is the likely pathology?
Sir, it is a embolic in embolic phenomena. It is insidious, it is acute onset, and it is progressively like a step ladder pattern. But in like a thrombosis pattern is mostly it is a sudden onset, and time between the onset and pickup it is between the times. And then you like hemorrhagic hemorrhagic pain, it is a catastrophic presentation is there.
Right.
Another like in infection impact your vasculitis, there is no any symptom yet present at this side.
Very good, very good. I will appreciate, at least from this point of view, that you have put it some of the points. Usually inflammation present with some fever, maybe infective, non-infective, some inflammatory condition. And again, it will probably take some time to develop. Your point is valid. Again, degenerative will be having the regression. That story is not there. Neoplastic usually even the slowly with the sense of raising the pressure and then maybe the motor deficit or something. Even trauma and other points are not there. So I think in short, gradually can focus toward the vascular pathology. Vascular again, that is another thing. Please remember that in vascular, particularly thrombosis is gradually developing. It takes some time, maybe even some hours or days. May not be very longer time, but it takes time. Hemorrhage is always catastrophic and different presentation. Even general condition of the patient will be quite different. Embolus is exactly what you said, that the healthy and hearty gall was sitting, suddenly noticed this weakness. And another characteristic that for initial few hours it is progressive, then it becomes the static. And the recovery starts within few days, what already you have described. I think that type of the story is more favoring some embolic phenomena. So I think pathology point of view, just we can put that maybe vascular incidence is likely. Among the vascular, probably highly suggesting some embolic phenomena. From where, how it has occurred, I think everything, again, we'll have to try to see history and examination and even other things. And I think etiology, that's why I said that we'll have to see that what is the source of this embolus, if at all it is there. Lot many points in the negative you have described. I think all the points we may not go. I think before we go further, let us take a word from Dr. Ritesh. Ritesh, can you put your, I will say, ideas and thoughts, and
Yes, sir.
can you take it further, please?
Yes, yes. So I think last 15, 20 minutes we are having very good discussion about localization and lastly about etiology. So in neurology, this is a basic rule that first you define the symptom, what you are dealing with. Many a times I see that there is a confusion in people's mind that what they are dealing with. So first define what you're dealing with. So here you are dealing with sudden weakness of one side that you have decided. Then, as Dr. Baldev said, where is the lesion? So you describe cortex, internal capsule, in view of UM and facial and all these things. So it all is okay. I just want to emphasize one simple point, but very useful practically, that whenever you are trying to define the etiology in neurology, in any neurological case, when you're dealing with, when you have decided your localization, then you're thinking about etiology. These are the very simple 4 rules, like divide the symptoms in hyperacute, acute, subacute, and chronic. So these are the 4 categories of your origin, duration, and progress, which we usually take the history. So hyperacute is within hours. Acute is within days, 2, 3, 4, 5, 6 days. Subacute is 10, 15, 20 days. And chronic is almost more than 1 month history. So if you divide your symptoms in this category, then each category has only 2, 3 common etiologies. Everything, there is an overlap, but all this time group, we have a common, like any hyperacute, you just have 3 etiologies. Any patient you see in your casualty with hyperacute neurological symptom, only 3 possible etiologies there: trauma, toxin, and vascular. These are the only 3 etiology which can present hyperacutely within minutes to hours. So here we are dealing with presentation within hours, 1 or 2 hours. So we are dealing with something, no trauma, no toxin, so something vascular, that is for sure. That is very good thing to have, that hyperacute presentation. If it is some acute presentation, like 1 day, 2 day, 3 day history, then common history is our infections. So all our infections usually present within hours to days. And right now, a lot of autoimmune and all these overlaps are there, but all these practically inflammatory etiologies. So all your infective inflammatory etiologies usually present acutely. Subacute is again chronic infections. Some autoimmunes also again subacute. And few tumor, but many times tumor usually have chronic history. So your malignancy will go in last category. Degenerative disease will go in last category. So tumors and degenerative disease always go in chronic category. Your vascular will come in hyperacute. Acute and subacute is dominated by infective inflammatory pathology. So this is a very broad subgroup of neurological etiology. When you are taking any symptom, whether are approaching paraparesis, hemiparesis, ataxia, acute flaccid paralysis, seizures, anything you are approaching in neurology, keep these 3, 4 categories. This is very simple, historically very simple to differentiate. So before this, what we are dealing with is very important to define. That many times you are not sure what you are dealing with. I see a lot of wrong sometimes concepts regarding what they are dealing with, whether they are dealing with hemiparesis, monoparesis, paraparesis, quadruparesis, ataxia. So here it is very sure. So first thing in neurology is define the symptom, then define the location, and then third is etiology. So here Baldev sir has nicely described about anatomy, so I'm not going in that detail of anatomical detail. In etiology, this is the broad subgroup which I have told you. And in subgroup, suppose now we are in hyperacute subgroup, and in hyperacute subgroup, we have a vascular that we are sure. In vascular, just keep it very simple. 2 etiologies: thrombotic, hemorrhagic. These are the very just thrombotic. Actually, we usually call it ischemic. So ischemic and hemorrhagic. So what is the difference? How can you differentiate clinically between ischemic and hemorrhagic? So as everybody described very nicely, that hemorrhagic is usually catastrophic, vomiting, headaches, seizures, altered sensorium. So predominant symptoms of hemorrhagic vascular presentations are headache, vomiting, seizures, and altered sensorium rather than weakness. While in ischemic presentation, focal deficits predominate. So your hemiparesis, monoparesis, facial, aphasia, all this. So focal deficits will predominate in ischemic etiologies, while your headache, vomiting, seizures, altered sensorium that will dominate in hemorrhagic etiologies. This is a very broad. We have to take all lot of points in taking consideration, but this is very broadly. So in this patient, we are dealing with hyperacute, so vascular. Amongst vascular, no headache, no vomiting, no seizures, no altered sensorium from history. So mostly some ischemic. Amongst ischemic, thrombotic, embolic, that we need a lot of other information, but we can, and that much detail. So for PG point of view, for your at regular practice point of view, these two things is very important. Decide whether it is vascular, yes, and amongst vascular, ischemic. So I think out of this history, I could conclude that this is some vascular etiology going on, mostly ischemic. That is my take out of all this discussion.
Thank you very much, Dr. Ritesh. I think he gave this very fantastic approach. I think I would like to take it further, very appropriately Dr. Ritesh mentioned. In any system we want, always try to define this category. Very appropriately said it is hyperacute, acute, subacute, or chronic. Second thing, always, even you can put in this way, ask the questions to yourself. That what type of disease it is. Is it static? It is progressive? Or it is really improving? Even suppose progressive, you can ask even this next question, it is rapidly progressive or slowly progressive? That will also give you even the lot many ideas regarding the categorization of the disorder. Not necessarily one particular etiology, but certainly that what type of the disorder it is. And even at the end, what is this present status of the function of this particular organ? And that will give the idea that how much this function is compromised. Even that will help you for further planning the management and even how you can even take it for this good punishment. So I think these points are very, very appropriate. Please remember another thing in the history. It is, I think, for again any system, but more so for the nervous system, that 80% of the diagnosis should be revealed only from the history.
And that is particularly true in pediatric neurology.
Yeah, pediatric neurology, what is it? Yeah, rather than the adults even. And even physical examination, many times it may happen. So I think let us see in our patient also will try that before going for the examination, make up your mind that what you are expecting on examination. And suppose if you get something different, go back to the history, probably something we have missed, or probably maybe some unusual, some other condition, which probably you have not thought of. So I think, that will help us a lot. And accordingly, naturally, then you plan for the investigations, for confirmation, exclusion. And I think that's the way that how we can go for this approach in any neurological case. So I think here already we have discussed this mainly history part. Many points negative we have mentioned to exclude. I think we may not go into the details to exclude the involvement of sensory system, even whether it was due to either inflammation or infection, or even the other parts of the CNS is involved. So I think, okay. But again, here I would like to mention for the students, negative points make the very precise, not the very long list to exclude all the neurological conditions. Pertaining to your case, that suppose whatever you are thinking, suppose here you are thinking for the vascular cause, then try to find out which points will strengthen your possibility. So that will be helpful to you. Dr.
एक
Harsh,
दिन और देखना है मेन चीज है कि
Dr. Harsh, can you mute yourself? Dr. Harsh, please mute yourself. Or I think this IPSA can do it. Okay. So negative point should be, I would say, taken in that way, that the possibility, what you are thinking, that favoring or unfavoring points, and probable explanation. Second, negative points, group of the negative points should be considered, which can differentiate the nearby conditions. And third, usually expected complications to your case. So I think only this type of the points should be selected in your negative points, not all the points of neurology to exclude that some degenerative and space occupying and infection and everything. Because it becomes very obvious what Dr. Ritesh already classified. That yes, it is a hyperacute condition, probably toxin and other things are not playing the role, and it becomes quite evident that it is the vascular. And okay, I think restrict to your thoughts around that, focus around the part, and find out the negative points. Anyway, I think rest of the other negative points, history part you can complete. Then again, we'll be back to the discussion. And I request again all the students that please participate in the discussion by keeping your video on. Then and then the purpose of solve of learning. Please, Dr. Anuj, you can take it further.
Yes, sir.
Yes, Dr. Anuj, go ahead.
Yes, sir. Uh, yes, sir. Antenatal history. There is a regular antenatal visit taken, and iron folic acid and TT was taken. No antenatal any
And
event.
Anuj, just one point. I think it is one for other students also. When you are present in this case in the exam, suppose, I think 12 years old girl who is presented with a circuit problem, hardly it is having any relevancy to this birth history also. Am I right?
Yes, sir.
And therefore, of course, you will have to gather the information. You should know. But while presentation, you can say that antenatal birth history postnatal, I got in the details. Probably every event was found normal. And this has nothing to do with relevance to this present illness. So I think that becomes a good presentation, right?
Yes. Sir, antenatal history, birth history, and postnatal history, it is uneventful. Immunization, according to national immunization, last vaccine taken is a 5 year of age, and BCG scar present. Developmental history, all milestone achieved as per age. At present, child is studying in 7 with good scholastic performance. Family history, history of similar complaint in father 3 year back in a form of weakness in over right side of association with convulsion and on medication for same. There is no family history in mental subabnormality, cardiac defect, hearing, vision abnormality, bleeding disorder, malignancy, anemia, or premature death, or storage disorder. And nutritional history, child requirement calories 2000 and recurrent is 1800. So means 200 calorie deficient, and protein is no protein deficient is there. So at present, my summary is a 12-year-old developmentally normal female born out with a non-consanguine marriage, presenting with the sudden and non-progressive weakness of the right side of the body, with a deviation of the mouth to the left side and aphasia on the 1 day duration, with relatively preserved sensorium, without any neonatal illness and significant palsiness, with family history of father having a weakness of the one side of the body, with apparent nutrition and partially immunization.
Okay, can you stop sharing?
Yes, sir.
Yeah. Dr. Harsh, can you take it? Or I think Dr. Vikram. Dr. Vikram, can you make your video on? Or Dr. Maulik is also there. Dr. Anjali, anybody? Please participate in the discussion. Dr. Anjali, can you participate? Can you take it further?
Sir, I wrote multiple times, but I don't know students why they are feeling so shy. They are
No,
not participating at all in discussion.
on the contrary, I will tell that this is not a good sign. You may
Yes.
you may hide yourself, but you know that you'll be deprived of even the knowing, and the same thing happens in the exam, because you will not be able to speak. Unless you speak, unless you participate, unless probably even we do some mistakes, and that's the whole process of learning. So we should not be afraid of that something what I speak may be totally wrong or something. No problem. I think even here what we are discussing may not be even absolutely 100% right. That always there is some lacunae, but it's the thing that how all of us learn. Anyway, Anuj, what I wanted in the exam, suppose summary is there. Summary should not be the repetition of the same points which already have discussed in the history. I think summary we want to put in such a way that what is your thought process? What is your interpretation? What is your inference from the history? What is your hypothesis? And I think already what we discussed, that you can try to answer that what is the anatomy, what is likely pathology, and what is possible etiology from this obvious discussion. And then you can put some of the common conditions as I will say, possible functional diagnosis. So I think that will be, that exercise will be better. Can you make one attempt to put in that format?
Yes. Yes.
Even some of the points what Ritesh already pointed out, you can take the help of, I will say, discussion. Definitely it is going to be useful, that how you can put it. Make one attempt, no problem.
Sir, 12-year-old female child has a complaint of weakness over the right side of the limb and deviation of the mouth to the left side. It is a one-day history. It is acute in the nature, hyper acute in the nature. So mostly due to the vascular origin in the and
Okay.
so associated with the such a positive family, positive history in a family.
So how will you link with this illness of this girl? Is there any link? That means, is there any disorder which can be in the even the multiple members of the family can be affected?
Sir,
Or are you considering some different illness with the father and different illness with this girl? What is your thought? How will you take it?
if we consider the correlation, so it is some like in a precoagulant condition, like in any proteins, clotting factor deficiency like protein CS or ProS deficiency, like or hyperhomocystinemia, lead to the familial relation between. It is a condition.
Right.
It is a correlation between them.
So I think here you may not be clear, but at least, of course, you can consider that these type of the facts are known, whether it is there in our patient or not, that you would like to explore the possibility after examination and even some basic investigations. So I think that point is valid. Anyway, what was my idea that how best we can put it very simply, the history summary. We can say that here the 12 years old female is as presented. From the discussion, it is quite obvious that she was sitting and acuity the problem developed with this weakness on the one side of the body, that is the right side. With this involvement of face, indicating the facial nerve involvement, and even the motor part of the speech is affected. In the absence of even the fever, absence of seizure, and even other catastrophe, and other features, it becomes quite clear that rather than the other etiology, it is the hyperacute condition. What already Dr. Nitesh mentioned, that hyperacute you can consider, is there any trauma which is not there with the history, some toxin, somehow there is no any background to consider, and therefore some vascular pathology is likely. Among this vascular pathology, probably hemorrhage is probably, it is down, and this embolus or even the thromboembolic phenomena we'll have to consider. Many a times it may not be very clear-cut only embolus, maybe even the thromboembolic phenomena, and then which may present with the sudden embolus in this way. So I think that we can consider, and we can say that even develops suddenly, remain static for a day or two, and even started to improve. I think that story is quite favoring that likely the embolic phenomena. What is the reason for this particular pathology? At least there is no any background, any cyanotic heart disease, history of bacterial endocarditis, or some source which is possible for the embolus. And keeping in mind, we have to explore the various possibilities. Regarding the father's illness in the past, having a similarity, we are not sure whether all the two illnesses to father and this daughter is different or having some link. But of course, some remote, I will say, possibilities, less common conditions, but we'll have to keep in mind after proper examination and even some of the possibilities indicating we may go for further consideration. So I think all the points you can put, which becomes quite convincing to the persons. Dr. Nitesh, is it all right? Should we go further examination?
Yes, I think we should go to examination and then we'll discuss.
Yeah. I think before again the examination, Anuj has examined the patient. So some person who is not examined, I think can answer, but difficult to get any of these. Names are so many. Nobody is, I will say, keeping their video on. And even the participating, even without making the video on, you can participate, no problem. Anybody will try to answer that what you are going to get on examination in this patient, or even specifically what you will examine to see whether this finding is there or not. Any person? Dr. Vikram, would you like to do? Or Dr. Anjali? Anyway, I think in absence of these responses, Anuj must have examined. So I think for this question to him may not be the right. Anyway, Anuj, you can share your PPT and go for examination.
Yes.
Hello, sir.
Uh, general general examination. Patient lying comfortably in bed with a IV cannula in left arm, spontaneously eye opening with the meaningful contact present, moving left body but right upper arm, lower arm lying limp, extended and externally rotated with minimal movement. Anthropometry examination. Child weight is 39 kg and between the 3 to 15 cm. Height is 151 centimeter between the 10 to 15 cm. And BP is 3 to 15 cm. And SMR stage is 2. Vitals is a temperature is normal by 97/6 with by digital thermometer in right upper axilla, and heart rate is 98 per minute, regular rhythm, pulse, no specific characteristic, no radiofemoral delay and radio relay. All peripheral pulse well felt and equally on both the side. Respiratory rate 20 per minute with the thoracoabdominal. CRT is less than 3 centimeter second. SpO2 is 98 percentage on room air. Blood pressure in a left upper limb is a 102 by 82 and right upper limb is a 110 by 80 mmHg. Central nervous examination. In higher mental function examination, the child is alert, consciousness with spontaneous eye opening. She is obeying the motor command on the left side with intact non-verbal gesture with communication. Other part of the higher mental function, including the orientation, memory, attention span, perception, insight, and calculation, individual lobe function assessment could not be tested owing to be limited verbal output. Glasgow Coma scale is 15 by 15. In speech, verbal output is markedly decreased, although comprehension, naming, writing is preserved. Fluency, reading, and articulation could not be assessed owing to the paucity of verbal output. cranial examination, all cranial nerve examination within a normal limit, but in facial law, forehead vehicle present, expression normal, blinking normal, forceful opening of the closed eye is normal, anterior two-third of the tongue taste sensation, but in a deviation of the angle of the mouth to the left side. In a motor examination posture, child is lying in a supine with the paucity of movement on the right upper limb and lower limb. Right lower limb is lying held externally rotated, external and lateral border to put to the suggestion of the right sided hemiparesis. Bulk bilateral symmetrical in both the side and upper limb and lower limb. In a it is tone is right side is increased and the left side is a normal both in upper limb and lower limb. In power, shoulder elbow is power is decreased is 1/5 in right upper limb and lower limb both the side, and reflex is in upper limb is grade 3 bicep tricep and supinator, and lower limb is knee and high right side is a +3 reflex and grade 3, and left is a normal. In superficial reflex or superficial reflex is a preserved, abdominal reflex is absent, and plantar in a right side is extensor and left side is a flexion. Sensory system superficial, deep sensation and cortical sensation is normal. Cerebral system examination, no nystagmus, no intestinal tremor, and coordination to the not tested on the right but left side is normal. No signs of meningeal irritation, spine and back normal, and no autonomic dysfunction. Bladder and bowel control is there. In a systemic examination, no obvious deformity on the inspection and equal moment on the chest on the both the side. On palpation and no tracheal deviation. On percussion, equal not audible on the both the lung. And auscultation, air entry equal and no adventitious sound is there. Central nervous system cardiovascular system examination, S1, S2 heard with no murmur. Abdominal system is all gotten more equally with the respiration. No visible abdominal swelling. Soft, non-tender with no organomegaly and bowel sound is present. These all summary.
I think can you just stop sharing?
Yes, sir.
Dr. Nitish, can you take this examination?
Yes, yes. So I think from history, you are, as Dr. Baldev sir has told, that everything should be gradually getting more focused. So we start with broad and go to narrow diagnosis. So after history, you have something in mind that something is vascular, you're dealing with some hemiparesis. You already know before examination that you're dealing with something. So out of all your 6 heads of examination, your higher mental functions are normal, cranial nerve is and facial. Your motor system has a lot of findings that we'll discuss. And other all reflexes and sensory are all appropriate to your motor, like sensory normal, reflexes are brisk in low limb. But in motor, what one thing is confusing to me in your examination is tone is increased in right upper lower limb, which is on first day of illness is little difficult to explain. It is really increased or it is decreased? Usually it is decreased. So I'm just confirming the finding. By mistake you have written increased or it is really increased tone? Usually it is decreased on first few days and then it
yes, sir,
increases.
Decrease in tone in upper limb and lower limb. Yes, yes.
So it is hypotonia. So rather than increase, decrease, use the term hypotonia or hypertonia. You should use the proper scientific term. So it is hypotonia in upper and lower limb. Rather than increase. Yes, yes. So that just correct that finding. It is not increased tone, it is hypotonia. So your hypotonia on one side of the body, and then you mentioned about your power 1/5 that is just flickering. Reflexes are brisk on one side and plantar is extensor on right side. So these are the 3 positive findings: hypotonia, weakness, brisk reflexes on one side, and extensor plantar on one side. So motor system and reflexes, 2, you have some positive history. So these are the just 4 positive findings in your history.
And speech, sir.
Speech. Just what do you conclude from the speech examination?
Sir, it is a motor means motor because of the comprehension are all present, but not speaking.
This is little more complicated, little more detailed, but just before jumping on to it is motor. Speech doesn't have just 2 components. Okay, so there are 2 things in speech disorder. One is aphasia. which is usually cortical function. And second is dysarthria. Sometimes, many a times, because of severe motor involvement, also patient cannot speak. And as soon as motor part improves, he starts speaking. So there is no aphasia there. It is just dysarthria.
Yes,
Okay.
I think-
So here you are dealing with dysarthria or aphasia. What do you feel? Then you go in details of aphasia, dysarthria, because your second day of onwards, morning patient started speaking, which is very difficult to explain in aphasia. So as Baldev sir has already told in your history, that very dense hemiparesis, extremely dense, without any seizures, altered mentation. So because of severe compact pyramidal involvement, you may sometimes get just dysarthria because your facial oromotor muscle fibers are also not working. So as soon as they start some improvement on second day, they start speaking. So it could be severe dysarthria also. So you're not sure here that you are dealing with aphasia or dysarthria.
Yes.
Okay, so don't complicate your things at this level. Just make it very simple that patient is not able to speak on first day of history, and on examination he started speaking few words. And so don't comment that it is aphasia.
Okay.
Here actually we are not dealing with aphasia. Aphasia doesn't recover in one day. It is very extremely rare to aphasia to have recovery in one day. Okay, so so here this is mostly dysarthria which is started improving. Okay. Okay, so just summarize your case and list of differential diagnosis. Sir, you want to add something in examination? Baldev sir.
Excuse me,
Hello?
sir. I want to add some cranial nerve involvement. I think we have left, na examination part. Cranial
It is
nerve
you,
was seventh cranial nerve. Yes,
upper motor neuron facial. He has already
yes,
mentioned,
yes,
I think.
yes, sir. He has mentioned.
In history only, actually, he has mentioned that patient is able to close the eyes.
Yes,
So he has
yes,
made it clear that eyes is not involved. So it is not element.
yes, sir. That's
Okay. So UMN facial, hemiparesis, hypotonia on one side, brisk reflex on one side, extensor plantar on one side. 5 positive findings. Make
Yes.
it clear, Anuj, that you have presented beautifully, but all these 5 things, you really mean it. You really see in the patient, because it is very difficult to see all these things unless you see in thousands of patients. It's very difficult sometimes to see brisk reflexes. Somebody will tell normal, somebody will tell brisk, somebody will tell this is normal tone, this is hypotonia. So it is very subjective. All this tone, all these brisk reflexes, power again. So you need to have a lot of experience. So as you are presenting very beautifully, kindly make it a habit of examining in all patients and write down normal or abnormal, because at this level, after 20 years in neurology also, we sometimes have a disagreement on whether this is a hypotonia or normal tone. Okay, so it is not so simple. So just make it a habit to examine in every patient all these things.
Yes.
Okay, you can go further. Summarize your examination. I already summarized, but you summarize yourself and give us a diagnosis, differential diagnosis, 3-4 diagnosis.
I think Dr. Anuj, Ritesh, can I take some points and then we'll go for
Yes,
this
sure.
further discussion?
I'm waiting for you
Yeah.
only. Yes.
Yeah. Actually, I had to go for some work. I think, Anuj, what Ritesh was mentioning, that initially hypotonia is expected, and most of the times, yes. How do you explain that? Ultimately, what type of lesion it is? Upper motor or lower motor?
It is upper motor neuron.
Okay, if you say upper motor and hypotonia, how will you explain?
Because of the
Because I think most of other your features, I agree with you. You have described and must be, I think, indicating upper motor neuron type of lesion. But the initially, and I agree with Dr. Ritesh, probably it may invite the trouble in the exam on the second day or first day if you say this hypotonia. In spite of your upper motor neuron type of lesion, most of the times we get the hypotonia. And then what is the explanation? And even if I give some hint for your thought process rather than confusing you, yes, after a few days, that will be the quite obvious hypertonia. That means basically it is hypertonia. Agree. But initially, why there is a hypotonia? And I think that should not confuse you. You should be able to answer that yes, it is upper motor neuron type of lesion, having all other features obvious. But regarding tone, initially hypotonia, I'm sure that this is going to be hypertonia within few days. Then the point is, what is the explanation for initial hypotonia? I think other students can also answer. Anybody? I think Dr. Lata was participating. I was happy. Just I joined and she was responding something.
Sir,
Even Dr. Vikram.
yes, sir. Due to the decreased activity of the spinal circuit, suddenly input from the motor cortex and brainstem. So might be hypotonia in first few days.
Sorry, I think there is no clarity.
Sir, suddenly,
How this cortex and brainstem will
suddenly
influence?
depend the input from the motor cortex and brainstem due to the upper motor neuron damage. So decreased activity of the spine circuit. So hypotonia might be possible few hours.
I think we know that this upper motor neuron type of lesion in this patient, we decided internal capsule level. Then probably that is the cortex is not playing the role, brainstem is not playing the role.
So it is like spinal shock situation. So initially,
Absolutely, yeah. You are knowing that why you are hesitant.
sir, actually, I was giving chance to students to answer. As a faculty, I think students should have first.
Yeah, I
chance
think
to-
Madam, oh, Dr. Lata is faculty.
Yes, sir,
Sorry,
I'm not
sorry,
present.
sorry.
It's okay, sir.
then naturally I think there will not be discussion, but there will be
સાહેબ
the
તમે
more
હો ને એટલે
clarity.
બધા તમે હો એટલે બધા સ્ટુડન્ટ જ હોય.
No, no, Ritesh.
Yes, sir, that's correct, sir. That's
On-
absolutely correct.
on
We
the
are all
contrary,
students.
on the contrary, I will take in this way that already those who are knowing and they do not need probably much to learn, they are participating. And those even I know that Ritesh is participating. I am participating. Already Dr. Lata is there, but I think other students should join.
Yes, sir, that
And
is.
then we can learn. I think Lata,
Yeah.
what I will request you at least prepare your students to participate next time or somewhere.
Sir,
So that it
definitely,
becomes,
sir.
yeah, that is good.
Hmm.
You know, Anuj, so what Madam answered that initially this is a shock-like picture.
Yes.
And therefore, this hypotonia is even obviously expected. With this recovery from this stage, that is going to be the quite hypotonia will be obvious. And therefore, you should not be confused that yes, in spite of hypotonia at present, it is the upper motor neuron type of lesion. And I think next question, you were discussing regarding the speech. Suppose your performance is good, somebody is going to ask you, how will you define the speech first? Any idea? And then what various disorders Ritesh was pointing out, I'm sure that if you are clear, you may not be have the confusions. You can answer. You know, please remember that usually speech, how we define. The speech is a faculty of communicating, right? Or expressing our ideas and thoughts. We takes in the form of some symbols in the form of the words, which may be written or spoken word. And that is the speech. I'm sure you know, is that speech and language both are same or different? Many times probably we are using interchangeably, but you have any idea whether both are same or different?
Same.
Okay, yeah, because most of the times we consider in this way,
Yes.
but both are not same. Of course, both are for the communication, agree. But speech already we define that here there are the two components, motor and the sensory. First, the person takes the sensations, interpret it, and response in the form the motor part may be the spoken or written. Right? That is the motor part. But even beside this also, you know, suppose some child is not able to speak. in the case of some cerebral palsy or due to some other reason. But still they are communicating. How they are communicating?
Because hearing is the normal, sir. It is hearing is
Suppose
very
hearing is
normal.
normal. Okay, hearing is the first pillar. But here, what is my point? That in spite of not able to speak, there are some other modes of the communication. Which are they? Even sometimes adults also, suppose in this viral season, it is possible that some of may develop even the dysphonia, aphonia. Then how will you communicate? Many a times you are showing some signs. Suppose if you want to write, you are showing in this way that you are asking for the pen, right? Or even children will show some gestures for passing the urine or stool, or you are demanding for water or food, right? So gestures and signs, these are also the part of communication. And that is beyond the speech. And that as a whole, if we say it's a language. So language is probably beyond speech. And even the various gesture signs if you include. So that's the main difference between the language and the speech. The speech is just as complicated, not that easy. And it is said when we were students, it was obvious that if you reach to the discussion of the speech and bladder vowel, probably you have done the good performance. So speech also, and what Dr. Ritesh said, I think in this case, our case, that's why I was in the history also pointing out that speech is involved, yes, but there is no any other, I will say, point indicating cortical involvement. Then how selectively only speech center is affected? Probably not convincing to us. And therefore, always give the second thought. That of course, inability to communicate, inability to speak, but is there any other reason for this? Absolutely, what Dr. Ritesh was pointing out, aphasia is the central disorder. Aphasia, nominal aphasia, right? These indicate that the motor part is affected. Here, at least we can keep it, and very I will appreciate Ritesh, I will say his way of teaching very appropriate. Keeping this not able to speak. Rather than I will say giving it this nomenclature that aphasia or dysphasia. It's not able to speak. And here probably, speech can be due to the central problem or articulation or phonation or even the functional problem. And all these are the problems of speech, but due to the various reasons. Phonation, that is the laryngeal problem or dysphonia. Articulation, all of us know in a cleft palate, severe weakness, even dehydration, electrolyte disturbances, person is not able to speak. These parts even may be due to the weakness. Even some chronic illness, person is not able to speak fluently or I will say with a good tone. So that's a different issue. At the same time, we know that problem of even just stammering, it is a functional issue. It has nothing to do with even the whole nervous system problem. So I think there's a point that you should try to locate that what type of the problem with the speech involvement. And I think I agree with Dr. Ritesh. Very easily we can explain with this motor part weakness. And that is there with this I will say, story, which becomes very easy to explain, which becomes, I will say, palatable. Most of the people will accept us. So I think having these points, and fortunately, I will say it's a good case for the exam. Suppose if you get it, because you can, I'm sure you can demonstrate even the dependent reflexes and extensor plantar, and why the abdominal reflexes are absent in these patients. Upper motor neuron type of lesion. And what happens in the lower motor neuron type of lesion to the abdominal reflexes? Any idea?
In congenital hemiparesis, abdominal reflex is preserved, but in acquired cause, abdominal accuracy absent. Because of the affected reflux arc leading to the absent of.
Okay. So I think already you have made the summary. You can just present it and you can go for the investigations. Last slide, you have to prepare the summary. Let us see that summary, what you are thinking.
Yes. Yes, sir. So, summary is it is a 12-year-old developmentally normal female child born out with the non-custodial marriage, presenting with the sudden and non-progressive weakness of the right side of the body with deviation of the mouth of the opposite side with aphasia on the 1 day duration with relatively preserved sensorium without any neonatal significant past in it, with family history of father having a weakness on one side of the body with appropriate nutrition and partial immunization with right-sided hemiparesis with right upper motor neuron, 7 nerve palsy with motor aphasia with pressure higher motor function. Lesion ideal, it is internal capsule. Pathophysiology is thromboembolic phenomena like acute stroke and arterial in nature involving the circulation of the left distal internal carotid artery or middle cerebral artery causes either a vascular, hematological, metabolic, inflammatory, or intracranial space occupying lesions.
Okay. Now would you like to change the statement or saying?
The cell is lights.
You know, that is another thing. Aphasia, absolutely what Ritesh pointing out, aphasia is not going to recover in this way.
Yes.
On the contrary, what happened, as you mentioned that the patient started to recover from other motor deficit point of view also.
Yes.
At the same time, you said that the child is now able to speak even. Some few words you mentioned in the history, right? That means that part is also recovering. Even second, I'm sure that the facial also must be the phase of recovery. So all the three phases, three components which were, I will say, damaged or lost, they are going for the recovery. So it is not very obvious that this is as a whole the motor part of the motor deficit rather than any the central cause. Suppose, Anuj, it may happen so in the exam that this type of the case, I'm not sure after how many days you have examined this patient?
4 months.
No, no, what I'm telling you, after this development of the problem,
Yes.
when you have examined the patient for the presentation.
After the sir, second day of illness, sir.
Yeah.
There,
But suppose after a week you examine, your findings are going to be changed. And suppose the same case is kept in the exam. Now what the problem will develop, that this still motor deficit will be there. That is the right side of the body. Both, I will say upper limb and lower limb. But the facial weakness may be the doubtful. And even the speech might have become the normal, possible. So how will you explain that? In the exam, somebody is going to ask you that you can see the facial is almost recovered. There is no any facial deficit. Speech is normal. Then how will you say the internal capsule lesion? How will you explain? I'm sure that this type of question is going to be there. And most of the cases, what happens, that hemiplasia, they are in the phase of recovery and kept in the exam. So examiner is going to ask you to demonstrate the present findings. And then he will link to the past, what you are describing the history. That you said in the history that indicating the asymmetricity, that with facial nerve. Here facial nerve is totally normal. So how will you explain? And this happens in the exam. Anybody? Anybody can take it. How will you try to explain? And I know I have even this several times seen they asked the question.
Sir, it might be, sir, vascular cause, so recirculation or develop to the reperfusion develop to the central nervous system.
Yeah, but it should be there with this even motor part also. Still, if you see the hemiplegia, there may be even the power 2 or 3. So it is affected, still it is there. Facial is normal. Anyway, I will give you the idea, and I'm sure that this is going to be the common question from most of the examiners. For the recovery in this type of the deficit, lateral part of management, what will you do? Whatever may be the etiology.
Rehabilitation.
How will you do?
Physiotherapy or
Physiotherapy. So physiotherapy helps for the recovery.
yes.
But how the facial now physiotherapy has, I will say, recovered earlier? Just keep in mind that the facial muscles are having the natural physiotherapy. You know that our facial muscles are used in different actions, I will say, not many times in a day. They don't any specific physiotherapy to put the muscle in the action. Automatically, with this, I will say, person is trying to use that muscles. And therefore, most of the times what happens in hemiplegia also, facial recovery is always earlier compared to other components. So it is a natural recovery. So I think in the exam you can say that the facial has recovered by the natural physiotherapy, and this motor deficit, what is there with the limbs, will require the still physiotherapy. In the due course of time, gradually recovery will be seen. Right? So I think that's the thing. Similarly, even, and that is another thing, because child has started to speak, that means it is not the central cause. Certainly you can say, even the retrospectively now. So I think these are the things which people are going to ask in the exam, and even the good for us in the practice also to explain and to understand. So I think having this now, let us go for the investigations, whatever you have performed. You have any investigation presentation?
No, sir.
Okay, you don't have the investigations. Anyway, then I think let us go to Dr. Ritesh. Dr. Ritesh, can you take it that what investigations we should perform in this type of patient?
Yes,
Please.
yes.
Yeah.
So I think for last 70 minutes we are discussing clinically. So now discussion we should direct to two directions. One is to establish the lesion, whatever we are suspecting, that we are suspecting some left-sided MCA territory, not extensive, but some M1 segment, M2 segment, whatever, in lenticular stride, whatever, but some left MCA territory in ischemic insult we are suspecting. So first investigation is to
See it.
confirm the
MRI.
site of lesion, confirm the anatomy. Okay, so first investigation is to confirm the anatomy. So get an MRI done. MRI with diffusion weighted images. So MRI with DWI images will give you the perfect answer that there is some ischemic area, diffusion restriction in some left MC territory, whatever, internal capsule area, some scattered here and there, whatever. Then along with MRI, whenever you are suspecting vascular cause, and in 12-year-old child, you are sure that this is some thrombotic or embolic, always order MR angio along with MRI to know the etiology, because second part of investigation is etiological investigations. And amongst etiological investigation, the first 2-3 common etiologies for stroke, one is like vascular pathologies, so that MR angio will give you the answer. So always order MRI brain diffusion weighted images with MR angiography. That would be your first investigation in this case. If patient is not otherwise acutely ill, so you're not going to like do A, B, C and all this your PICU management, because you are telling that patient is conscious and everything is normal. It's just a patient in ward or sitting in a OPD. So first investigation would be MRI diffusion weighted images with MR angio. Then once you confirm that you are having ischemic stroke and probably MR angio is showing some thrombosis or whatever. So now you have to go for etiological investigations. So before I do some lecturing, can you tell me what are the common etiologies of stroke at 12-year-old female? 12, you are considered 12-year-old female, otherwise normal, sudden stroke. What are the possible 2-3 common etiologies in your mind?
Structural heart disease like rheumatic heart disease, infective endocarditis.
Okay, so one is heart disease, which will give rise to embolic strokes. But suppose your MR angio is showing that your just bifurcation of ICA at some MCA level, there is some sudden thrombotic area. There is some just MR angio is showing complete occlusion of your MCA, and it is a thrombotic. There is no embolic phenomena, no scattered strokes, no scattered etiologies.
So
Then,
vasculitis.
just okay, vasculitis. We'll go in detail of vasculitis because in pediatrics, the commonest etiology of stroke is actually vascular pathologies rather than cardiac. So cardiac is very obvious from history and examination. A lot of cyanosis, clubbing, your murmurs, your heart sounds, blood pressures. There are a lot of other evidences in cardiac. The cardiac stroke will not come without any cardiac findings.
Yes.
Usually, you will never find an CHD in a stroke without knowing that this is having some underlying cardiac disease previously. So you usually have some clinical cardiac findings in patients with embolic stroke. So here, no doubt you'll do 2D echo and you'll do some cardiac consultation, but it is less lower on differentials. Okay, so get an 2D echo done. Any other investigation for cardiac cause?
Sir, in a vasculitis, where the non-infective vasculitis like polyarthritis nodosa or Takayasu arthritis, like non-infective moya disease or any or infective like infective vasculitis.
So just okay.
Yes.
So okay. No, I am telling you about vascular. We already discussed. We'll go in detail of vasculitic lesions. One is vasculitic, one is cardiac. What is the third common category?
Hemoglobin, hematological,
Yes.
most like hemoglobinopathy like sickle cell disease causes like thrombocytosis.
Yes. So common things are always first. So first categorize 4 major categories of stroke etiology. So one is vasculitic that we'll discuss in detail because that is most common. Second is cardiac. For that you get an 2D echo done. Third is hematological. You get an CBC and sickling test done. If suspecting something like in our South Gujarat area, sickle belt, get an electrophoresis done. Otherwise, CBC and sickling test will be enough for hematological investigations. What is the fourth category?
Prothrombotic, procoagulating style like protein C or OS deficiency, hyperhomocysteine.
So don't go in detail. You are very fast. You people are very fast. Go categorically. So hypercoagulable states. Okay. So this is the fourth category. So just go step by step. There are 4 categories we have discussed. One is vasculitic category. Second is cardiac category. Third is hematological category. And fourth is your hypercoagulable states. Out of these 4 categories, think of common conditions and do investigation accordingly. So for vasculitic category, you get an MR angio done. For cardiac category, you get an 2D echo. If needed, some doubtful finding, ask cardiologists to see 2D echo, even transesophageal echo to see the PDS and all these things. But a patent foramen oval, because it sometimes is not seen in routine echo. So you need transesophageal echo. You have to get the probe from esophagus and do the echo from behind. So that is the echo part. Hematological, CBC and sickling test, enough. Your hypercoagulable state. Again, there are 2 categories amongst hypercoagulable state. One is primary hypercoagulable state, which is genetic conditions, protein C, protein S, what you are mentioning. And other is secondary hypercoagulable state. Actually, in our practice, what is most common is secondary hypercoagulable states like nephrotic, leukemias, dehydrations. So all these things will cause secondary hypercoagulation. So in routine practice, amongst hypercoagulation, common is secondary causes rather than primary causes. So investigations are extensive. Okay, it will cost a lot of cost to your patients without which very less yield. So hypercoagulable state, do workup for primary hypercoagulation, which is available in form of thrombophilia profile or thrombotic profile or something. A lot of things are there, but don't go with these profiles. These profiles are misleading. They are just for marketing gimmicks. Okay, so keep in mind that there are 3, 4, 5, 7 common things, and you see whether your profile is including all these things or not. So one is testing for primary hypercoagulous state, that is your thrombophilia or thrombotic profile. For secondary hypercoagulous state, according to your clinical history and examination, if you are suggesting something, then go for investigation. Otherwise, just keep in mind. So now coming to these patients. So these are the 4 categories of investigation I have mentioned. Okay. 4 etiological groups, accordingly you investigate. Suppose 2D echo is normal, CBC is normal, cycling is negative, your hypercoagulous state report mostly will come negative. Actually, I will not order all in this patient because before ordering hypercoagulous test, I will order MR angio, and I think I will get something in MR angio in this patient. Okay, so if MR angio is showing some clear-cut thrombotic lesion or clear-cut some etiology, some moya pattern or something, then don't go for this fancy test which is costing 20,000-30,000 to the patient. Okay, so now I think we have time of another 15-20 minutes. Sir, at what time we are going to finish?
Yes, sir, 8 o'clock, no problem.
Okay, so I think this is we can have very good discussion on stroke etiology. So how will you approach your, so we very loosely say vasculitis. What is vasculitis? So hello.
Yes,
So
sir.
very loosely we say vasculitis. What will you make in your mind? Like, how will you categorize vasculitis in your thought process? What do you mean by vasculitis?
It is vascular inflammation leading to the.
So vascular inflammation is what? Vessel is what? Vessel is one pipe which is having what?
It is an endothelial inflammation leading to the
Okay, so vessel, there is a intima, media, external, three layers are there. So in intima, whenever there is some inflammation, you usually tell them vasculitis. There is some inflammation in the intima of the vessel, and because of that, there is a damage to the endothelium of the vessel, and because of the damage, the platelets get added, and you get some thrombosis. You get some clot there because of endothelial damage. So primary pathology is where? Primary pathology is in endothelium.
Yeah.
And endothelium is damaged, that we call as a vasculitis. So amongst vasculitis is a very vast topic, but in pediatrics or in our practice, what are the 3-4 common vasculitic conditions you see in your practice? Anybody can take part in this discussion. So in amongst vasculitic category, amongst primary vascular pathologies, what are the common 3-4 etiologies? What you have mentioned while you are mentioning polyarteritis nodos and all these things, these are there, but they come in last in differentials.
Infective vasculitis.
Which infection? Here we are talking about this patient. We are not broadly discussing.
Dr. Ritesh, Dr. Ritesh, I think I should come to his rescue.
Yes.
I think because number one, let me appreciate. I know Ritesh since many years, but the way in which probably not he knowing the only subject, but he knows how to teach. I will appreciate.
Thank you, sir.
To know the subject and to teach is different. And the way probably he's taking very, very appropriately, methodologically, categorically. And I'm sure that if we have this approach, what even he said, to be very frank, I like it very much. Then don't go for the profile, which is probably very common practice at present, everywhere, not only in neurology, everywhere. And that profile hardly probably helps you. Many times we invite the trouble because confusing. There will be some 2-3 things positive. Which one you will consider positive? So plan your investigations according to your, I will say, thought process. And what Dr. Ritesh is taking, I got his point to us on the discussion from the vasculitis point of view. Basic points of the vasculitis in that there are 3 means, I will say, vessel size point of view vasculitis.
Yes.
That small size vasculitis, medium size, large size. And if you go even for each particular examples, you come to know. Now, Anuj, I want to sensitize you so that I'm sure that it will help Ritesh to take it further. He said that regarding this patient, now he's focusing. Suppose here it's a 12 years old female. Start from that point. It's a 12 years adolescent. It's a female, right? And here, suppose if I give some background, may not be in this patient, in some other patient, that yes, the patient had some joint pain or even some skin rashes in the past.
Yes, really.
And now she has presented with stroke. And the SL is known to go for even these neurological complications. Maybe that is also type of the vasculitis. And what he wanted to say that we take the common. Of course, even the polyarteritis nodosa, Takayasu disease, the large size, medium sized vessels, vasculitis are there, but somehow in the pediatrics not so common. So take it common, and I think from this point of view, Ritesh, I think you can take it further. I wanted to talk regarding 2-3 points. One is the no profile, that is very important. Then always categorize. That is very important. Maybe infective, maybe non-infective. Like I see stroke also, he said very nicely. That take the common group. One is the vasculitis group. Go later on. Then the hematological. Then the cardiovascular. And check one by one. Some things will be excluded. Some will be more focus. And then you can find out the common conditions. Plan for the investigations. I think that will help us a lot. Dr. Nitesh, you can take it further. Sorry for interruption.
Okay, so I think amongst vascular category, now what I see in my practice and what is theoretical also we'll discuss in minutes. So as you mentioned that there is no history of varicella. Why you mentioned that?
Post
Anuj, you mentioned no history of varicella in your negative history.
How it is relevant? Yes, Anuj.
sir.
I think Anuj, why varicella history you asked? No history of varicella?
So post varicella angiopathy is one of the complication 3 to 5 week, 2 to 4 week after the varicella infection, leading to the infective vasculitis, leading thrombosis and produce a stroke.
I think contact on the Ritesh side is lost. Anyway, you can take it further. What you said, absolutely right, that the chickenpox is known for this complication and usually after 6 to 8 weeks or so, right? So that may be one of the reasons. What are the other reasons for this vasculitis? Dr. Ritesh, are you there? I think there was some net issue.
Am I audible?
Yeah,
Am I
you are
audible?
audible. You are audible, please.
So from varicella, what do you expect? Anuj, anybody can say. From why you asked no history of varicella?
I think he said that the vasculopathy is known for like the chickenpox. That's why he.
But now we are PG students, now we are MD going to get it. So just don't go in terms. What will actually happen post varicella? What vasculopathy means? What we are all discussing vasculopathy.
Yeah.
What will happen?
What happens to the vessel?
So the term is focal arteriopathy. So arteries, some segment of the artery. So it is called focal arteriopathy and usually it recovers. So it is called transient focal arteriopathy. Okay. So it is not only varicella actually. As you have seen and a lot of consultants say, many viral infections, any viral or even any infection even sometimes can give rise to stroke after a few days of infection. So it is basically either immune reaction or direct toxin mediated of the infective agent. Nobody is sure, but whatever either infective agent or immune reaction will cause endothelial, arterial endothelial inflammation focally. It is not generalized. Whole vascular system is not involved. It is just a focal segment. Suppose 1 centimeter segment of MCA is involved. So it is called focal arteriopathy. And usually it is transient. And when I was doing my PG, even before my residency, like before my neurology, when I do my PG in VS, that my PG teacher, Dr. Aaron Joshi sir used to tell that Any influenza, any viral sometimes can give rise to minor strokes, which usually recovers. At that time, we are not doing MR-NG also, but they have something in mind that these infections can cause stroke. So this infection can cause focal cerebral arteriopathy, which is usually reversible. So it is called transient cerebral arteriopathy. That is the most common cause of stroke in pediatrics.
Yes.
So out of all four etiological category, amongst vascular, almost 30 to 50% patients will have a transient cerebral arteriopathy, and which is most common after varicella. So we take the history of varicella. But any infection can cause, and you rightly mentioned in your history that there is no recent infection in the past. That is the purpose of taking history of infection, that there is no infective complication of focal cerebral arteriopathy. And focal cerebral arteriopathy is usually a retrospective diagnosis. Transient word comes retrospectively. So at your initial presentation, it is focal arteriopathy. After 4 to 6 months, patient is completely recovered, your MR-NGO is completely recovered, then you can say it is a case of transient focal cerebral arteriopathy. So amongst vascular cause, commonest is focal inflammation in your vessel, post-infective. Again, in pediatrics, infections are most common. Same here, infective complication is most common. That is the first cause amongst vasculitis. Second is moya. Extremely common. Amongst vasculitic pathology, almost 20 to 30% patient will have a moya. So moya again, two types, either primary moya or secondary moya. What is moya? Can anybody just say what is your understanding about moya? I don't want definition or some detail, but what do you understand by moya?
It is a supraclinial internal carotid artery collapsing leading to the recirculation developed.
So primarily, supraclinoid ICA is stenosed.
Yes.
Usually the disease is bilateral. It may present unilaterally, but usually it is a generalized disease. So usually it is a bilateral disease. Bilateral supraclinoid ICA is stenosed, causing lot of revascularization, so it is called puff of smoke appearance, which is a Japanese word. So there is, you can see beautifully on MR-NGO, beautiful pictures. Even routine MRI also people can diagnose who see MRI properly. So MR-NGO and MRI will give rise to that lot of collaterals are developed. So it is a chronic process, long-standing process, and some decompensation which lead to your acute, hyperacute presentation. So bilateral disease, supraclinoid ICA, either primary or secondary. Secondary can be due to many causes. We'll not discuss moya here. Our idea is to discuss the categories. So amongst vascular, most common is focal arteriopathy, which is post-infective. Second is moya, which is usually primary. 70-80% primary, 20-30% secondary. Third is, which many people miss and which I see very routinely, is dissection of the arterial wall.
Yes.
You heard of dissection?
Yes, sir. Anterior neck trauma or leading.
Yes. So football, yoga, lot of contact sports, cycling. Recently, I've seen one patient 3 months back. Beautiful dissection on vertebral artery. We can see on NG also. So dissection, again, it is a tear in the intima, tear in the vascular intima, which cause the vessel, blood to flow from the intima. It will go in media, and there will be another track in the vessel, in the media, and again from some other injured part, it will come inside the vessel. So there is a two flow you can see. So you can see that a vessel is dissected in two parts because of two injuries at intima level, and blood is flowing from the behind the intima, between intima and media. Okay. And dissection is usually common after trauma, particularly in adolescents. And usually commonly happens in posterior circulation, not in anterior circulation. So here we are discussing anterior circulation stroke, MCA stroke. So here dissection is unlikely in your case. Okay, there is no varicella, no infection. So transient focal arteriopathy is also unlikely in your case. Could be some unnoticed infection or something, but unlikely. And the fourth category, what you are all telling is primary vasculitis. And in primary vasculitis, there are two. Some are primary CNS vasculitis and some is systemic vasculitis. Amongst primary CNS vasculitis, primary CNS angiitis is most common. And among systemic, your SLE is most common. This is the broad group I have given you. So amongst vasculitic category, you have four groups. One is focal arteriopathy. One is bilateral ICA, occlusion because of moya. Third is your dissection. And four is real inflammation of all vessels, which could be again CNS specific, which we call primary CNS angiitis, or it could be part of your systemic vasculitis, like SLE or whatever. This is amongst vasculitic category. We have these 3-4 categories. And in your patient, if you do MRNG, you will get the answer whether it is a dissection, it is moya, whether it is a focal cerebral arteriopathy, or it is a generalized arteriopathy. So out of these 4, you will get something. The radiologist should be very good. The radiology again is a very misleading branch. So you have to tell your radiologist all your clinical details, what you're expecting, discuss with radiologist. It is not just that you send the patient for any MRI and get the report and treat accordingly. You cannot do that. You have to be in close loop with your radiologist when you are evaluating a case of stroke. Okay, because very important imaging features are there. And they are also very loose sometimes if you are not discussing with them. So discuss with radiologist. And amongst this 4 vasculitic category, differentiate on basis of your MR-NGO. They're dealing with what? If you're dealing with focal arteriopathy, don't worry. Just give aspirin. Patient will be fine in 6 months. If you're dealing with moya, you have to go with surgical. If you're dealing with dissection, you have to give heparin. If you're dealing with primary vasculitis, then deal lot of steroids. So all management is different. So it is not very simple job, just physiotherapy and aspirin. Okay. So according to your etiologies, you have to have a long-term management strategies. So out of this vasculitic category, out of this 4 category, in my practice, I see all 4, but the commonest is transient focal arteriopathy and moya. These 2 are more common. Then third is dissection, and then comes vasculitis. What we usually discuss, what we usually read is all SLE. These are common in other systems, but in pediatric neurology practice, SLE presenting without any symptom with directly stroke is very unlikely.
Yes, yes, very unlikely.
Okay. Okay, so I think I have given enough lecture.
Yes,
Actually,
yes. No, I will appreciate. I think he has given a very good thought process, concepts that how we should go for our analysis of the given situation. I think what he said, let me go for the revision or the recapitulation for the sake of the students. That first, even from the history, from the symptoms, try to define exactly that what you are dealing with. I think it is very important for any system, more so particularly for the CNS. After categorization of the symptoms, try to decide that what you are dealing with. And that very simply you can do even from the history, details of the history. That what type of the anatomical localization, and then this possible pathology. Of course, etiology may not be possible from the history at all. Examination of the CNS is very, very important. And I think another thing for the exam point of view also, if you are asked you any short case of any system, relevant general examination points are very, very important. That we'll have to check, even in systemic examination. Suppose if you are asked for the hepatosplenomegaly, but look at even these systemic points. That is there any jaundice? Is there any lymphadenopathy? Something like that. So I think CNS point of view also, many times we'll get many points, particularly the measurement of blood pressure, even some of the skin manifestations, neurocutaneous, some markers, something that will give the idea for even the further thought process. That's very, very important, that relevant general examination points and to be noted on the paper. Then how much importance should be given that you can correlate later on. Next phase comes that how will you examine the CNS? I think examination is very, very important. Particularly, I think very cranial nerves point of view, very specific cranial nerves common, which we should know every person. And I think same, they were going to be asked in the exam. Then the motor system, and ultimately what I wish, probably sensory system, most of the examiners will not go in the details because they know that even in adult with a good understanding also, it's very difficult. And that in the young children, we don't expect much. But whatever suppose obvious that you can put in. Ultimately, what is my idea? That put all the points of positive findings on the paper. That will give you the idea, give some image that what type of the CNS problem, where is the site of lesion. From that, later on, as Dr. Ritesh discussed at length, that categorize that what type of problem it is. And then consider the common causes first, and then plan for the investigations. Don't go for the battery of investigations, that any investigation for severe stroke. And therefore, you ask even everything for the severe stroke, irrelevant to even your patient, is not helping. Many times, suppose some 2-3 things are borderline or indicating positive, then rather than help, it becomes a confusion. So even for the investigations also, now we are going for the diagnostic stewardship, or what we are discussing, antimicrobial stewardship, like diagnostic stewardship. We should have the answer that why you are asking for these investigations, what you want to see, what you are expecting, and how that investigations will help you, either for the diagnosis, or does it make any difference in your, I would say, plan of management, in what way it is going to be useful. I think we should have, in short, good explanations for performing that investigations, not randomly as it is, I would say anything can possible and you can go like that. So that is, I think, very important message, and I will appreciate that Ritesh is having that, I will say, our thought process. Usually I'm emphasizing so much for any investigation that what is your idea, even similarly for drug. So I think this concept is very important. We should have, okay, my explanation may not be right, but I have some explanation. That reasoning should be there. And I think that is very important message. Of course, that will give you the idea for even further management also. And then your management will be very precise. And I'm sure that we are expecting the good outcome if you are following the whole academic exercise. So I think our idea of this discussion is not to get the very one particular cause or etiology or condition, but how we will think, what should be our thought process, how we should proceed further, how we'll categorize, how we'll consider the various possibilities, and plan for the further investigation and management. So I think very nicely utilize almost 2 hours, and I'm sure that I will appreciate that the Ritesh on the contrary helped in a definitely very appropriate way. Even let me mention that I also noted several points, Ritesh, and I learned that yes, these things are quite useful in our daily practice. Certainly. So I think because somehow today only Anuj was the person to answer, still I will appreciate. Anuj, what you should do, I will say next time I will request you and Dr. Nihal also. Nihal is taking so much pains, so sometimes I become really reluctant that now I should not pass on something to her. But I think you can prepare some of your friends, whoever is presenter. From that institution, I think others are coming, that is good and most welcome. But otherwise, even you can request your friends to come, not only an attending link, on this panelist link. And even, please, very important, never hesitate to participate in the discussion. Nobody knows the subject as a whole. On the contrary, several times, let me mention, in my round it has happened, and some of my students must be knowing, that I have discussed for 45 minutes or 1 hour for very specific condition. And next day, my resident tell that nothing is there from your discussion. It is something else. It happens even, I will say, even today. And I will say it's not, that's the thing that why we are discussing. That's why we are learning. And it happens in medicine. So I think even in spite of learning for more than 40 years pediatrics, I think so many teachers are also having the same experience. So why the students should have the hesitance? This be on the contrary, you should be very free. Suppose something even I am not able to answer, I will take the help of Dr. Ritesh. We have the expert. And even if he's not knowing, I'm sure that he will say very frankly that, oh, I'm not sure, I do not know, we'll have to check it. Or we'll have to read even. And it happens many times. So I think I want to break down this, I will say, barrier, hesitation, reluctancy. And unless you know that you speak, to be very frank, even many of my friends are asking, why every week I am taking 4 hours in Tuesday and Saturday. So many friends are asking that for what you are doing. I will say, yes, I have also some interest. And that is to learn the pediatrics. Unless I discuss, unless I interact with all of you, unless I listen to Dr. Ritesh, how I'm going to learn further? Otherwise, what will happen that whatever I'm knowing, it will be restricted. So I think this is the thing that how we can grow. And therefore, I think students should not have the hesitation at all. I'm sure that next time we'll get some improvement with our efforts. And I just it's a part of teaching. So I'm never disappointed. It happens so. But we'll continue in even the better way. And I'm sure that gradually they will join us. Thank you very much, Anuj. You did, I would say, very good job. And I'm sure that we should appreciate even Ritesh. He did a very good job. Probably not only knowing the subject, but how to even put the student, ultimately knowing, but how to explain them, that it goes to the person. It's a little bit difficult job. But I'm sure that as we continue, we are able to do it. Ritesh has done a good job. Thank you, Dr. Nehal, for taking so much pain and continue the show. And ultimately, I'm sure that it is going to be useful to all of us. Thank you very much. Over to you, Dr. Nehal.
Ritesh bhai wanted to say something.
Sure.
Just I want to congratulate Anuj for excellent presentation. He has done a good job.
Yeah.
Very good job, Anuj.
Today it was one-man show. So
he has presented nicely. Very nice presentation.
yes. So it was really very nicely prepared, Anuj, and congratulations to your mentor also, Bhumika.
Yeah, I think I should appreciate Dr. Bhumika also. I understand that she must have taken lots of the pain for preparing the student.
Good presentation.
Yeah.
Yeah. Thank you so much, Anuj and Bhumika, and thank you, Ritesh sir, for giving such nice inputs. When Baldev sir says that he had got some hints and he had pointed some notes, then it's really a thing to be commendable.
Yes, we all learn from him.
So, and thank you so much, Baldev sir, for taking it so nicely. I will try, sir, to motivate the students more
Yeah. We'll have
and
to
participate
motivate.
in the discussion.
Yeah.
Yeah, sure. Thank you, Clarinet, for providing.
Thank you, Neil. Thank you for inviting.
Thank you.
Thank you.
And good night. Good night to everybody.
Good night, everybody.
Thank you, sir. Thank you, ma'am.
Thank you, Dr. Bhumika.